going to talk about the why CSO exists. Thank you, Dr. Bishal.
Good evening, everyone. Thank you very much for being here with us today. I'm very, very happy to be here to speak about CSO. As mentioned before, it's a new movement. We started 2 years ago in Kingston, Queen's University, but has now global support from colleagues all over the world. And we are especially pleased to be hosting this event here in Barcelona today while ESMO Congress is going on, because we have been receiving several messages of support from colleagues in Europe, especially about how we can join this movement and how we can be a part of it more formally. So this was like a nice opportunity for us to gather with you all and have this sort of informal discussion about what CSO is and what we are planning to do. So I'm very, very thankful to the Rio group because this was impossible for us to organize without the support from Rio group and local members. To organize this place and the catering and the bus and everything, those logistical challenges, it was impossible for us to do from Canada. So all this is happening today because of you all, so thank you very much. Really. So let's start about common sense oncology, why we exist. Other way around. So I wanted to show you this slide. This is from a couple of years ago, published in JAMA Health Forum, in which they looked at cancer mortality rates, adjusted by smoking, of course, across different high-income countries. And they looked at how much these countries are spending on cancer treatment and what their mortality rates they are achieving. So if you look at these graphs, one thing is obvious, that the mortality rates, they don't depend on how much the country is spending. So you could be spending a lot. For example, US is an outlier there. On the far right axis, it spends almost $600 per person on cancer treatment. And the mortality rate, if you look, it's just at the median. There are many countries which spend far less but have excellent mortality rates. And there are some countries where the mortality rate is not as good despite spending more. So what this graph clearly shows is cancer mortality outcomes do not depend on how much we are spending on cancer treatment. And that is eye-opening. If I compared a couple of countries there, just to give you an example, like Canada and US. For example, US is spending $200 billion every year. Canada is spending only $10 billion US dollars every year. But in terms of per person, it's $600 per person in US and almost $300 per person in Canada. Of this, 10% is on prescription drugs. So prescription drugs, the cancer drugs that we're using, they constitute an important percentage of how much we're spending on cancer treatment. But what are we achieving from that investment? For example, if we look at the US, from the $21 billion per year, what are we getting as a result? On average, the new cancer drugs, they extend survival by 2.9 months. So that's what we are getting. If we look at drugs registered in Canada for funding, it's 3.7 months. So I think we can argue that we are not getting as much from these drugs as we are spending on them. So the question is, why are some of our cancer drugs not delivering on this promise? There are several reasons. One is because of the trials that we are doing, and Dr. Van der Graaf will have subsequent talk on how CSO principles fit into clinical trial design and reporting. There is the role of experts, which I put in quotes here, because like it's easy to hype a drug that does not actually meaningfully improve patient outcomes, and it's easy to be swept away in that hype. And therefore we need to be very careful about who we listen to. And therefore there is also the role of education. Can we train people so that they can become independent judges of cancer drugs and trials rather than needing to rely on experts' opinion? And there is also the role of media, because many times this news reach patients faster than they reach us. And the patients, they just read the headlines and think that, you know, there is some really groundbreaking drug out there that they are not having access to. With ESMO MCBS group, Dr. Czerny is here, who we call the father of MCBS. We worked on this paper where we looked into several issues with clinical trial design, analysis, and reporting that can skew the interpretation of clinical trial results. That means on paper it will say that this is the new standard of care, but there can be so many flaws into the trial design and analysis and reporting that might have falsely given us the impression that this is the new standard of care, when in fact the trial, for example, may be comparing against an inferior control arm, or there might be problems with crossover, informative censoring, and several other issues. In this paper that we published in 2022, we discussed several threats to evidence-based medicine in oncology. And all of these threats, they undermine our capacity to judge the results of the clinical trials and then subsequently affect clinical outcomes for the patients. I'll give you a couple of examples. Examples are always better to make the case. So this is from BBC News, which is a reputed news source. And it says, remarkable therapy beats terminal breast cancer. What is there not to like about this? It's a remarkable therapy. It beats cancer, not just any cancer, but a terminal cancer. It's excellent. Like, what else do you need? But if you read this news article and try to find out what the source of this news is, then you see that this news is based on this paper published in Nature Medicine. And it had a huge alphametric score, like almost 2,000, which is humongous. Alphametric score gives you an idea about how much social media and media attention an article has received. And this has received amazing media attention. But if you read into this article, you find that this is about a patient. This is not even plural. This is one patient, right? A patient. And this has led to such exciting headlines, and the patients will read about it. So this is misleading news. One more example, and this time from prostate. So that trial, that phase 3 trial that I have put up, that led to these headlines. So based on that trial, the headline said, laser-activated drug is a leap forward for prostate cancer treatment. Amazing. It could be a game changer for men. Super amazing. Now let's see what it actually does. So if you read the trial properly, and of course it has amazing attention in social media and media. My articles, they don't even get 100. I'm not complaining. So this is the result. So if you look at the results, what do you notice? The rate of metastasis. You notice that first the control arm is active surveillance. That means you don't actually intervene except for surveillance. So you don't give anything to these patients. So compared to not giving anything, if you give this drug, this fancy new drug, what it does? Metastasis, it's 0 in both arms. Death, cancer-related death, it's 0 in both arms. So even if you give nothing, nobody is going to die. Nobody is going to develop metastasis. Now, how can you improve on a mortality rate of 0? You can't make it minus, you can't make people. So, like, there is no game to change. Although the headline says it's a game changer, there is no game to change. You don't have to do anything for these patients. They're not developing metastasis, they're not dying, and so there is no game to change. And therefore, we thought that, you know, instead of focusing on all these fancy new innovations, which are important, like we need new innovations, but instead of focusing on these fancy new innovations that do not improve clinical outcomes, we should be focusing more on how we can implement the strategies that we already know to work. Many people in the world, they die of cancer not because they don't have access to this fancy new drug that was announced just yesterday. They die because they don't have access to surgery, pathology services, radiotherapy, and so on. So we should focus more on how we can make sure everybody who has cancer in this world, irrespective of where they live, will have access to these fundamental treatments that improve their lives. And that is what the philosophy of cancer ground search is all about. We are focusing too much on moonshot And we are ignoring cancer cancer totally. The cancer cancer gets no funding. But if we can't implement something, what good is a new drug that does not reach anyone? So I'll give you an example. We published this paper many years ago about cancer treatment in the last 6 months of life, when inaction can outperform action. So we have seen multiple research showing that patients in the very end of their life, in the last 6 months of their lives, are still getting cancer-directed active treatments and suffering from lots of side effects, and that is not benefiting them. From a New York Times article, I do not want to say the name of a person because idea is important, person is not important. But what it says here is a certain oncologist asks patients, do you want to try an immunotherapy drug before you die? So that is how much of hype, like it was like 5 years ago, now it will be CAR T, and 5 years later it will be something else. But it's always about that fancy new drug, which we mistakenly believe might help our patients at the very end of their life even. When in fact, studies have consistently shown that patients at the end of their life, they would far more prefer to preserve their quality of life. So that is what New York Times termed as desperation oncology. From evidence-based medicine oncology, we have moved to desperation oncology. And the stages of grief have changed from denial, anger, bargaining. There is nivolumab in between. Grief and acceptance. So we need to recalibrate our priorities. So that last 6 months of life paradox, where we were spending hundreds of thousands of dollars on patients for a treatment that does nothing to them, but we do not have enough funds to send them a social worker, to send them personal support worker that would actually meaningfully improve their lives. And I think this is very much consistent with the theme of the ASCO annual meeting last year. I bring that up because our president of ASCO from last year, Dr. Sukhtar, is here, and our chief medical officer from ASCO, Dr. Julie Grelo, is also here. Thank you so much for coming here today. So as an oncology community, we need to ask, do we want to work on these marginal gains? Do we want to meaningfully improve patient outcomes, and what does that mean? So in 2017, when I was writing blogs for eCancer, at the time I jokingly asked, like, you know, maybe we need to start a center for sense in oncology. We're starting all these new innovation centers for precision medicine immunotherapy. Maybe we should also start a center for sense in oncology. And because basically what we are saying, in my opinion, is common sense, that our drugs should meaningfully improve outcomes of our patients. And if they don't improve their longevity or quality of their lives, then probably they are not very meaningful. That's similar to saying, if you see a glass door, push. If that does not work, pull. If that does not work either, probably we are closed. So we focus on 3 aspects: delivery of care, research and policy, and education, to bring about this CSO movement. And in 2023, in Kingston, Ontario, this group of people met and we started a movement, and we published our, these are the founding members, and we published our philosophy, our sort of manifesto in Lancet Oncology, in which we outline our vision and mission and principles. So shout out to the first author and my mentor and my colleague, Dr. Chris Booth, who is a co-founder and co-leader of this movement. So our mission is to ensure that cancer care focuses on outcomes that matter to patients. And this is our vision, which you can read in detail. I'm not going to go through each of them. But at the heart of this movement is we need to be focusing on outcomes that matter to our patients, and how do we ensure that happens in an equitable way to everyone in the world. So right now we are working on 3 pillars of evidence generation, evidence interpretation, and evidence communication. So, you know, it all starts on evidence. So how do we generate proper evidence? That means how do we design clinical trials well? How do we interpret it? That means how do we report it properly, and how do we infer inference from there properly? And evidence communication, how do we communicate it properly to the patients and the media so that there is no misinformation? So we currently have 5 project teams at CSO working on different priorities. And this is our bottom line. CSO will promote interventions that measurably improve the lives of patients. We will celebrate well-conducted trials and promote effective treatments, but we will also speak up about and challenge interventions that might cause more harm than good. So thank you very much, everyone, again for being here today. It's a pleasure, and this is an informal gathering, as I mentioned, and even after this talk we'll be here, so we can, well, I look forward to chatting more and discussing more about this. Thank you.
Thank you. Thank you.